Good afternoon, everyone, and thank you for joining us today. My name is Kayla Heckman, and I'm the chair of the Health and Wellness Task Force. Before we get started on today's CLE program, I have one announcement on behalf of the section, and that is that our View from the Bench seminar registration has been extended. And so there's last minute availability. So if you have not registered yet and want to attend, please do so. View from the Bench seminar is on November 6th in Tampa and November 7th in Miami. With that, I will introduce our speaker today, Dr. Sarah Y. Vinson. Dr. Vinson is a triple board certified physician who specializes in forensic psychiatry. Dr. Vinson is the founder of Lorio Forensics, a mental health consultation company, and has consulted on cases in over a dozen states and testified and been admitted as an expert in state and federal courts. Today, Dr. Vinson will lead an interactive presentation on the why, how, and who of engaging mental health experts for trauma evaluations. Today's CLE code is 9481. And if there's any questions, put them in the chat box. And if there's time at the end of the presentation, we will try and answer them. And with that, Dr. Vinson, you can take it away.
All right, thank you so much. And thanks for having me today. And please, if you have questions as we go, my goal is always to answer them as we go along. It lets me know what's relevant for you. And I don't want you thinking about something from slide 5 when we're on slide 25. So it's not an interruption. Please feel free to put those in the chat and I'll be on the lookout for those. And Kayla, if you see something I don't, please um, just ping me and we'll make sure that's addressed. So the presentation today is about trauma evaluations and mental health experts, why, how, and who. And this presentation is informed by my lens, both as someone who does forensic work, but also as a provider and someone who has worked in public sector and private sector settings with adults and with children in settings where trauma was very prevalent. And even in the private practice settings, what I find is that trauma is some element of the story and what people are presenting with. And given my background doing child and adolescent psychiatry, as well as getting specialized training in trauma at Cambridge Hospital in the Victims of Violence program under Dr. Judith Herman, my role in a lot of forensic cases ends up coming back to trauma in one way or another. So what's ahead? I would like to start with definitions and some foundational concepts. So when you're thinking about how you explore these things in your case, the questions you form for your experts, what those consultations look like, these are things that I think will help you in doing that. We'll look at psychic injury in civil cases, mitigation or victim impact in criminal cases, the actual evaluation process and what you should or may want to look for in terms of how people are going about consulting with you. And then, of course, discussion. And I want to make sure that we leave a good amount of time for that at the end. But again, if you have questions as we go, please let me know. So definitions and foundational concepts. So first, what is trauma? I don't know, are people able to speak up or with the webinar format, can they not do that?
They will not be able to speak now.
Okay, so I ask you to think for a few seconds about what trauma is, what comes to mind when you hear that. And on a fundamental level, right, you're thinking about something that was a experience that stayed with someone and that stayed with someone in a negative way, right? That there were these ramifications of going through this thing that shaped someone, that shaped how they think, how they feel, how they behave, and that their normal ways of coping weren't able to deal with. They weren't able to get back to their baseline after this thing happened. And it's important to understand that trauma is different for different people. The risks of the different kinds of traumas that people may experience is going to vary depending on where they are, what they look like, their age. And so what is traumatic for one person or what are relevant traumas to ask about certain populations are going to be different. So this plays into this idea of health disparity. So these are differences in health status among distinct segments of the population, including differences that occur by gender, race, or ethnicity, education or income, disability, or living in various geographic localities. And if we look at mental health, if we look at mental illness symptoms, often, not always, but often, either the symptoms themselves or the risk of developing those symptoms are tied to trauma. So many health disparities, especially in the mental health world, are actually tied to disparities in traumatic exposures as well. And when we look at health inequities, it's a way of looking at those differences, but doing it in a way that is acknowledging that there are systemic, avoidable, and unjust social and economic policies that create barriers to opportunity when it comes to health, but also that create disparate exposures to potentially traumatic experiences when it comes to illness and things like PTSD. Health inequities are also something that is important to keep in mind when you're trying to understand what people have had available to them for treatment, how they've engaged, how they have not, because this can be really critical when you're trying to understand why people haven't gotten help, why people haven't been diagnosed, why there's no history. This actually comes up in my clinic that I do with the residents all the time, right? They'll come in and they're presenting the patient to me and they say, this patient has no history of mental illness. Well, what they really mean is that they have no history of treatment for mental illness, not necessarily that they have no history of mental illness. And because of health inequities, there's large populations of people that really do have a history of mental illness issues, but no documented history. And we'll talk a little bit more about that. So when we think about post-traumatic stress disorder, which of course is the diagnosis that comes to mind for most people when it comes to trauma, there are four really big buckets of symptoms. So the person has to be exposed to the traumatic event. There has to be changes in both how they think and how they feel that are tied to that. And of course, those are negative changes. And then re-experiencing, so things like nightmares or flashbacks. But I want to highlight the symptom cluster that is underneath the category of avoidance. Because avoidance isn't as dramatic as the flashbacks and the nightmares or the irritability. But for many people, it ends up being the most impairing set of symptoms that people with trauma or with anxiety experience. And what's taking place, right, is that because the traumatic event brings up those negative feelings, that sense of helplessness, that fear, that physiological reaction, all of which are very difficult for people to tolerate, that they don't want to experience, rather than put themselves in a position to be reminded of the incident, rather than talk about it, they just stay away from it. And there's a way that in the moment, in a short-term way that is effective, right? But over time, it can really get in people's way. They can't really start to understand or develop insight into what has happened to them if they can't talk about it. It can limit their exposure to other things. So if the traumatic event involves something at school, obviously not going to school at all is not just going to limit your exposure to things that remind you of the trauma, but to other opportunities and to developmentally appropriate milestones that someone should be going through their lives. And what you see with avoidance as well is that sometimes, even when people have insight, even when they have enough exposure to know that they could potentially benefit from or need treatment, it can get in the way of them being willing to engage in treatment because they're worried about falling apart if they start to kind of open those things up. And sometimes once they start treatment, the negative feelings that can come up with that exposure, with that vulnerability, can hinder continuation. And so when we're looking at trauma evaluations, part of what you're hoping to do is support somebody in dealing with that avoidance and navigating that avoidance in a way that is not overwhelming, that is not triggering, and where they have the support of their team, their family, and hopefully a treatment team as well, in terms of being able to overcome that so that that avoidance isn't getting in the way. When we look at PTSD, the populations that were in mind for the DSM's diagnostic criteria were really two sets of people. So, people who were soldiers, who were fully formed adults, went off to some faraway land, had a circumscribed experience, came back to the US, the threat is no longer there. Or women who were attacked by unknown assailants. So, not people they have to see again or that they're in a relationship with or that are part of their day to day life, but someone who was there did something terrible to them and went away. We understand that when trauma isn't a one off, or when it happens in the context of relationship, or when it's not in some faraway land or by some strange person, it may actually end up impacting people differently. And so you have people who can be immensely impacted by an event, by a traumatic event, but still not quite meet the criteria for PTSD because of the populations that were in mind when those criteria were developed. And this also applies to children. And so that's where you get into complex trauma. And so when we're thinking about traumas that have taken place over time in the context of a relationship that were inescapable or unavoidable, then that complex trauma framework can be really helpful because it's going to kind of prompt the evaluator, prompt the legal team to consider how not just, did they develop these PTSD symptoms, but how did this impact their relationships? How did this impact the way that they view themselves? How did this impact their emotional regulation and their coping mechanisms? Because those are all things that once that complex trauma is part of the picture may be in play at well. So we're thinking about trauma a lot of times, or even when we're thinking about mental illness, there can be this focus on the individual. And of course, it's the individual that is named or the individual that is the defendant. But in understanding people's vulnerabilities, their resources, and their reactions and responses to trauma, it's also important to do that with the lens of structural competence. And with this, you are recognizing the structures or systems that are going to shape their clinical interactions. And so it's not just a matter of diagnoses, but understanding how they've moved through the world and how that has contributed to their sense of fear, their sense of hopelessness, their ability to regain their footing or not. And not just pinning things on, people culturally or on groups of people, but really thinking about how not only what that person brings into it or what their culture brings into it, but what the practical ramifications are of how systems may respond to them differently because they are part of that culture. And then thinking about structural interventions for people as well. So when we consider some of the things that people may have experienced, it's not just about an individual harming them often. Sometimes it may be that a medical system let them down, or that they were dealing something like structural racism that had multiple levels, not just interpersonal, but also that were written into policies and laws that impact people. And so trauma is not just about, it's not always just about what the person can see immediately or what they articulate immediately as the harm. As you start to examine their life and understand it better, there may be traumas that they don't even recognize because they've kind of faded into the background noise because this has been such a part of their lived experience. And there may be beliefs that have been questioned or challenged now in a way that is harmful to them, in a way that is unsettling to them, that they may not have articulated yet. And often people are more aware of those interpersonal traumas and their impacts. But sometimes when it comes to these more structural or systemic barriers or things like racism that are part of just kind of the background noise, those things may be missed. So with structural trauma, you're looking at when society systems and structures, governments, economies, safety net services, as they are configured and you routinely operate, are instruments of harm. So you could see this when it comes to things like the child welfare system or maybe even sometimes the carceral system. But I'll give you an example of something that I often see in the school system. Sometimes I'll end up getting called about cases related to discrimination in the school system. And there is, this index event that got everybody's attention that led to the suit. But often there's already a complicated relationship with the schooling or the educational system that is playing a role in that as well. So, as someone who works in a public sector child psychiatry clinic, can tell you that often we have youth that come in and there are concerns about behavior, about lack of engagement, maybe even about things that are labeled as oppositional. And we examine the child and we find that there are things that are concerning for developmental issues or cognitive issues, that perhaps it's not that the child doesn't want to do the work, but they actually can't. And in order for that to be quantified, they need to get psychological testing. Well, in order to get that testing, you may be on a wait list for 3, 4, 5, 6 months. In the life of a child, an entire semester can be so critical in what their educational trajectory looks like. And so you have a place where they're required to go because they're mandated to go to school. And they're told that this is a place where they will learn, where they will get the tools they need to enter society, where they'll be able to dream and to grow. And rather than that happening, instead, it's a place where they are labeled, where they're discouraged, and where they're asked to meet standards that they actually can't. And it's the same system that is asking them to meet these standards that is failing to provide them with the assessment that is needed in order to know what that actual child needs. And what you see then, right, is continued academic disengagement, risk of dropout, and with risk of dropout comes risks of other types of systems involvement that can carry their own trauma, such as child welfare or juvenile justice. So I talked a little bit about PTSD because that's a diagnosis that always comes front and center for people. But depending on the trauma, depending on the person, they may not meet those criteria. And when it comes to trauma, PTSD may result from it, but what you see more often is actually depression. You also may have the development of things like anxiety disorders or substance use disorders. So it's important to understand that everyone is on a continuum between mental health and mental illness. Things like protective factors, supports, adaptive coping skills push people toward health. Risk factors, stressors, maladaptive coping press them toward illness. But it doesn't always fit the nice diagnostic criteria box. So when you're trying to understand someone's story, tell someone's story as it relates to trauma, thinking about it along this continuum and in this more dimensional approach, rather than they meet criteria or they don't, is going to give you a much, much fuller picture. So when you're going through medical school, even when the diagnosis seems pretty clear, they often will make you come up with a differential diagnosis. They'll force you to think of what else might explain what you're seeing. And so when that was the case, almost always, if you were kind of stumped on a diagnosis to add to that, you could always add lupus. And that's because lupus is this disorder, for those of you who are not familiar with it, where your body's mechanisms for fighting off infections actually turn inward on the body. And depending on what part of the body it impacts, you get different symptoms. And so when we think about trauma, I think of it as the lupus of mental health. Because it can impact people in so many different ways, the presentation can be quite varied. And sometimes, especially in a court setting where people like to have things that are more black and white, that are easier to prove and kind of put your finger on, that can be frustrating. But people who have worked with people who have trauma know how things may manifest and know to look for different ways that those things may manifest, but always understanding there is no singular right, correct, or valid response to traumatic exposures. Because what people bring in to that, right, where they were on that continuum between mental health and mental illness before that exposure, is going to affect what this looks like as well. So trauma can influence self and world concept. So you'll have people who may end up with irrational self-blame or guilt because of what occurred. And in some ways, right, that sense of, well, if I had done something differently, this wouldn't have happened to me, maybe their way of kind of rationalizing or feeling like they don't have to go through that again because they can just not do that thing they're blaming themselves for doing. But that takes a lot of work in therapy. Their world concept, what they think about people, how they see relationships, how they view the world as a safe place or not, and what that means for how they move through it also can be impacted. During a traumatic event, people may have overload to their neurological systems, their hormonal systems. And depending on what else is going on, depending on if they have pre existing conditions, depending on how extreme that was, there could actually be changes in their neural circuitry or in their the way their hormonal cascades interact from that moment forward because of the traumatic event. So with the cell phone world concept, there are things that they may be able to articulate to you if they're in a safe place, but there could also be these physiological things that are reactions that they may not even tie to the event always, but their body is having these reactions. Often you'll see where people, even if they know there's a change, they know there's a problem, may not be able to get the help that they need. Or maybe they were casual drinkers or casual substance users before it happened. And what you can see is this transition from alcohol being something they do to wind down, or marijuana being something they do because they like it, to those things actually taking away those distressing negative symptoms of trauma. So those neurological and hormonal impacts are self-medicated, if you will, by these substances. And when you start going from a substance being something that you like or something that's fun to something you're relying on, then the risk of addiction is going to increase. And so teasing that apart, right, the timeline of it and what people are using substances for and what their relationship was like before is really important. Depending on where people are in life, right, you may also see academic and occupational derailment. Um, I recently had a case of a young woman who had experienced a rape, and it wasn't just about her own academic derailment, which was striking, but also her mother's occupational derailment because of what it meant for how she had to show up for her, take her to appointments, manage these crises and things of that nature. And so, because you can have these externalizing symptoms that come with trauma, it's not just about, how that person feels, but it can also get in the way of really important responsibilities they have in their various roles in society. And then aggression and threat perception. And this is particularly relevant to people who have experienced complex traumas or complex or traumas in the context of relationship. Um, there are actually studies that are able to look at the way that their brains fire differently in response to things like neutral faces. That there can be this difficulty with knowing what people's intentions are. And because of that past bad prior traumatic experience, erring on the side of interpreting things as threatening or aggressive when maybe that's not actually the case. So this is something we talked a lot about in medical school, and I certainly see this in court cases as well. Sometimes clients don't read the book. In med school, they said patients don't read the book, but people can be profoundly impacted by trauma, but not meet criteria for PTSD or for complex PTSD. And that's why that narrative history and learning the person's background is so critically important. Now, it's not that once you're an adult, you are fully cooked. However, when things happen early on in life, when you're still trying to get through high school, when you're still trying to figure out what your strengths are, when you're still trying out different coping mechanisms, that trauma may impact you differently. So when you're looking at assessing or understanding the impact, it's not just about what happened, it's about where that person was in life, where that person was neurobiologically, where that person was psychosocially from a developmental standpoint at the time of the trauma as well. So the healthcare system, I'm a member of it. I try to help people through it, but I think it's always helpful to level set about what our system is able to do and frankly what it's not. And so I co-edited a book, Social Injustice and Mental Health, and in the healthcare system, the authors point out that perhaps it's a misnomer. Because the name implies the provision of health, but providers and policies often focus on the provision of clinical services. Care suggests that the focus is on meeting the needs of patients, but it's more so centered on the needs of providers and of payers, even more so. And system makes it sound like it's organized, cohesive, connected, but really it's this huge patchwork of things that often are in silos and don't work or talk together. So that matters because when people are trying to get help, when people are coming to you and they don't have a prior diagnosis, or they're coming to you and they have diagnoses that may be prejudicial, even, um, the context in which those diagnoses were made is not ideal for people, especially if there are complex traumas, structural traumas, traumas that we don't pay as much attention to. The structure is not ideal for those things to be understood. And sometimes it can look as if people are treatment refractory or difficult, or that they have nothing wrong with them. And it's really that the system was not configured to be able to greet them, to hold their story, to provide a sense of safety, and to give them the things that they needed to continuously engage. So in some cases, especially in public sector clinics, so Medicaid, your county clinics, that sort of thing, your diagnostic assessment may be as little as 30 minutes. So in that 30 minutes, that provider is trying to get current symptoms, past psychiatric histories, traumas, family history, medical history, educational history, work history, relationship history, get a sense of what treatments they're on now, who their supports are now, diagnose them, and come up with a treatment plan. That is a whole lot to do in 30 minutes. And so, what often happens, right, is that there's a focus on what symptoms the person is experiencing now, their past psychiatric history, maybe a couple of lines about trauma, and then trying to figure out what to do. And what that means is when you have treatment records or a treatment history, it's often not fully informed because the system is not set up to allow us to have the time to build the rapport and to get the information that we need. And what you have is that often those diagnoses are carried over from that initial insufficiently long appointment and not really re-examined, because then you may go down from 30 to 15 minutes or 20 minutes. And those systems experience a lot of provider turnover and disruption because, as you can imagine, when you're trying to help people, being forced into a system that practices that way can be its own sort of injury for the provider, and they have a very hard time holding on to people. And so for people who have been traumatized, having to tell that story all over again, having to have somebody who doesn't um, have a long-term relationship with you can be really difficult. And so I say all that to say that if you're just going by mental health treatment records, or if you're just going by whether they've engaged or stuck with treatment, it's really not a good barometer for what is actually going on with someone. So another way to think about this, right, is that all of us go through life based on prior experiences. And there are things that may tell us to pay attention, but that if we've been able to navigate them before, don't necessarily create a dramatic reaction in us. So an example of this is if a fire alarm goes off. So if we were in person, I would ask you all, if a fire alarm went off right now, what would you do? And often when I'm in a ballroom or a classroom and I ask that question, people say things like, I'd run, or I'd look around, or I'd see if I smell smoke, right? And I've actually had the experience of being on the stand when a fire alarm went off. And I can tell you that nobody in that courtroom ran out, right? People took a step back. They understood maybe it meant there was a problem, but it didn't necessarily mean that there was. And the reason for that is because for the vast majority of us, we've been in places where there were fire alarms, but no fire, where there was a signal we needed to pay attention to something, but not an actual threat to our lives. Now, if our lived experience was that every time we heard a fire alarm, there was a fire and people died and we got smoke inhalation, that fire alarm would elicit a very different response. Compare that to experiences or feelings of anxiety or fear. People who have had a repeated pairing of that feeling with an actual threat are going to react in very different ways than people who have had that feeling and they've ultimately been okay. So when you're thinking about trauma, understanding that for them, there is a intensity to the response that is grounded in their lived experience. And so understanding that background and that lived experience is going to be really important, not just as it pertains to the issue that brought them to court. So now let's go to civil and psychic injury. So with these cases, we're trying to understand what they were functioning like before, what their risk factors and strengths were before, what their experience was like during the incident, and then trying to understand those same risk factors, protective factors, and how they moved in the world after. So yes, you're looking for changes in diagnoses or symptoms or severity if there are pre-existing symptoms, but also what is needed to help make that person whole. My experience in doing these cases is that sometimes clients are not prepared for the amount of information that we have to get about what happened before the incident, and about the amount of exposure that they're going to have in terms of prior traumas and things like that. But it's important because it can help to explain to the court why their symptoms may seem out of the ordinary. So we hone in on function, right? It's yes, we want to know if they had diagnoses before, but who were they and how did they navigate the world? So, as one example, I had a case where a woman was actually a former beauty queen, and I was talking about the psychic injury aspect of a medical malpractice case that was an ENT issue. So there were the practical, implications related to her health, but for someone whose personal appearance was so central to her identity, that was another element of the injury for her. What aspects of their background or identity shape the trauma's impact? What have been barriers to recovery and treatment engagement? And then what is needed to make whole? And so when it comes to mental illness, one of the things that is so uh, striking about it is how it has the capacity to really derail multiple aspects of someone's life. And so when we're considering what it takes to make somebody whole, it's often going to be more than just therapy or medication, especially if symptoms have gone unchecked or they were at a critical developmental period. So thinking about children in like middle school or high school, what is needed in order to help repair those ripple effects that impacted other aspects of the person's life. And so, as a way of example, we're doing reports and there's been some significant educational derailment, right? We think about educational supports as part of those interventions to help complement the psychotherapy and the psychopharmacology that's helping to treat those core trauma symptoms to get that person back on track. Also, mental health problems can start to undermine key relationships. And when we're thinking about what people need in order to be functional, when we think about what is key to just the human experience, relationships matter. And so considering things like family therapy or couples therapy as part of that work, or as part of that package as well. And then as you're considering what people may need, because of those limitations in the typical mental health system, the public sector system, and even some when you are privately insured, people may need to go out of network. If you look at the House of Medicine, people who are in the mental health field are more likely to be out of network or in cash practices. Reasons for that are in a whole other, talk. But what that means is if someone is limited to only using insurance, you could have treatment disruptions in insurance. You could have treatment disruptions if insurance changes. But also there could be people that they need, skill sets that they require that they're not able to access with that restriction of only using insurance panels or public insurance. And so I will often speak to the need for people to be able to go out of network if needed, and comment on what that would look like if people were paying fee for service or out of pocket. So mitigation or victim impact in criminal cases. So in most of the criminal cases where people engage folks like me, the trauma is more of a complex nature. Um, Not more. It's tremendously complex in nature. And it was, especially on criminal cases, part of really their developmental history and their life story. And what you can have are things that were adaptive responses when they were under threat that become pathological responses when that threat isn't there or where they're in a different environment. Um, if you are in a neighborhood where you constantly feel unsafe, things like vulnerability or transparency are things that could actually be threatening to you. I was a fellow, well, a few years back now, but there was a young man who kept coming to the clinic or kept coming to the unit. So he would be fine on the psychiatric unit. He would take his medications, not get into any trouble at all while he was there. We'd release him, he'd go out, stop taking his medications. I'd end up seeing him back in the ER and back on the unit. And, I just asked him one day, help me, what's happening when you leave? Because you do great when you're here. And he told me that he didn't take his medications in the community. And the way that he phrased it to me is, Dr. Vinson, when I'm not on my medicines, people know not to mess with me. And the takeaway from that was he didn't feel safe as someone who wasn't irritable, angry, and reactive in the community and in the environment where he was. Because of how our field is structured, because of whose traumas we pay attention to, there are times that we are going to miss things. And when it comes to people in marginalized populations, the field of mental health is more likely to miss traumas that are relevant to them. So let's go back to that diagnosis of PTSD. The P stands for post-traumatic stress disorder. So the implication is that the trauma isn't happening anymore. Especially in the criminal cases I get for mitigation, most of those traumas are not post. They could still be current, and they were not ever circumscribed, right? They are just part of the person's lived experience and they are inescapable. And while we have post traumatic stress disorder, we don't have a diagnosis for traumatic experience that was part of the fabric of the person's life and developmental uh, trajectory. It doesn't exist, right? So what that means is that even when you have traumas like that, that are obviously going to be really important for understanding someone, our diagnostic criteria, our training, our 30-minute diagnostic evaluations that we do in clinic aren't always going to catch or capture these things. So they may not be counted in the DSM, and the DSM does not even include complex PTSD, let alone something for current ongoing traumatic responses. Even if you look at the criteria A for PTSD, things like neighborhood violence or racial trauma wouldn't necessarily qualify. And because there isn't a recognition of those things, what I've seen as someone who trains young doctors, as someone who ends up reviewing reports, is that they're just not asked about it, right? So I'm still adjunct. My primary academic affiliation is Moral School of Medicine, but I'm adjunct at Emory. And I was doing an evaluation with one of the Emory forensic psychiatry fellows. And there was a young boy that we were, well, young teen, like 13, that we were evaluating. And she asked him, do you have a history of trauma? Right? And she's going down she thought she was being diligent and she went down the 10 ACE criteria, right? And he's like, no, 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 right? And denying a lot of things. But then I talked to him and I asked, have you seen people killed in front of you? And he's like, oh, yeah, right? And so sometimes it's about what we're not asking But just because we don't ask doesn't mean it's not part of the person's experience, doesn't mean it's not part of their presentation. And so there's a need for structural humility as you're doing these evaluations because the DSM can lead you wrong. So that ACE questionnaire, I'm sure many of you are familiar with that 10 question questionnaire. My mom was a retired probation officer. They were even talking about it in her probation office before she, rode off into retirement. But that original questionnaire was normed on a largely white, largely college educated, uh, privately insured population in Northern California. The traumas relevant to that community and that patient group are not necessarily the traumas that are going to be relevant to the people that you're representing. And so when there's a reliance on these questionnaires, these risk assessments, these things like criminogenic risk factors without putting those experiences in context, we can miss a lot of really important data. And so we miss it in clinic, right? If you're trying to go by medical records or mental health treatment records, it just may not be there, not because it's not part of the client's experience, but because it wasn't asked about. And then that sets you up to miss it in court as well. And so now we'll go into the evaluation process. Um, so just looking at the different roles mental health clinicians may play. So as a treating clinician, right, you come in with a first do no harm charge. There's patient privilege, and it's all about addressing patient concerns and function. Um, and if you involve a treating clinician, and as a treating clinician, I've had people who have tried to, bring me into the forensic expert opinion side. Um, and we never want to do that. And it's not just because we don't want to go to court or we don't want to be bothered with it. But what that does is it gives your client maximum exposure. So if I'm on the stand, anything they told me about anybody in their family, about any aspect of their lives, would be fair game if I have to answer these questions. And as a treating clinician, I don't want to do things that are going to harm our treatment relationship. I don't want to do things that are going to harm this client because that's what I'm charged with keeping in mind as their treating provider. Um, as a correctional or a mental health clinician, uh, it's just when they're applying that treating clinician role in a correctional facility. Most people who do that kind of work aren't necessarily, forensic psychiatrists or forensically trained or people who did like a fellowship in it. And with that, the elements of the treatment relationship remain, but practically, what that looks like is significantly shaped by the environment. And shaped by the environment in ways where you're not going to get as much history, you're not going to have as much of a rapport, and sometimes there may be conflicting interests as well. With a forensic mental health consultant, these are people who have uh, additional training or supervision in consulting. They're not responsible for patient outcomes or for addressing patient concerns. It's all about answering your question. There's no patient doctor relationship, and the fact that they are being hired in this consultative capacity means that they can take a really deep dive as it pertains to your question, but that deep dive can be targeted. So they're not in the position where they are knowing things that could be potentially harmful to the case because they've had this unnecessarily broad lens or a longer relationship. So what the records reflect or don't. These are some of the implications for document review. So when it comes to these documents, right? Because you may not have the time, there could be traumas that aren't captured there. There could be surface diagnoses. And there could be a way that things that were previously diagnosed are just carried forward. And so it's helpful when you are doing these cases, not just to get mental health treatment records, but to get any sort of records that can help you understand how that person was moving through and interacting with the world. And so treatment records, even if they've engaged in treatment, despite all the barriers that can sometimes be in place to trying to do that, are often going to be incomplete. So things like school records, occupational records, child welfare are all going to be just as informative and often even more so than mental health treatment records are for these sorts of cases. So some things that are helpful when you are uh, going through this process, or when you're trying to figure out what expert is best to go through this process for your particular client, um, some things that would be helpful to bring to them, or that you would want them to be able to weigh in on. So knowledge of community and structural traumas. So things like zip code data, um, about the neighborhood, about the community where they grew up. Is the person informed enough to screen for relevant traumas? And are they asking you the questions to help fill in those gaps that display that there's a structural humility, but also being able to think about how this person may be vulnerable to structural traumas based on different demographics they have or prior life experience they have. When you're going through records and you have things like these surfeit diagnoses and descriptions of people, it's helpful if you're not just going through the record looking for diagnoses, but if you're going through the record and pulling out how the different symptoms being captured, how the different impairments being described could actually support the case for trauma, learning disability, developmental disability, even if that's not ultimately what the diagnosis is in the chart. As I'm going through and looking at these records, again, that people are often making under very stressful, high demand, little room for really thinking about it environments, what's most useful isn't so much the diagnostic part often. It is those symptoms that have been described. And then also recognizing that there's often bias and premature closure. So we know that certain gender, certain races are more likely to get certain labels attached to them. But also, and it's not just about the label that's attached to them, it's about the fact that once that label is attached, providers and sometimes even forensic mental health evaluators may not do as thorough of a job in exploring what other possibilities are because they think they already know what the answer is. And I'll say, especially when it comes to youth or people where those developmental issues are a big part of the story, that premature closure is often the bigger problem compared to the surface diagnoses. Depending on your client's background and what their experiences have been, depending on the sort of traumatic event that brought them to your attention, there could be mistrust of systems and difficulty with disclosure. And so some ways to try to combat this are validation and rapport building. So doing that work with the team, with the legal team before you bring an expert in, or realizing that the expert may need a couple of appointments or maybe two or three or four appointments in order for that to be addressed as much as possible. Consistency in approach and staff and policies and procedures that are going to promote that continuity. When it comes to impairing symptoms, of course, always thinking about the person's safety and considering what sorts of mental health supports can be put in place realistically in the environment they're in. And when you're accounting for that, what does that mean for how you go about doing the work? What does that mean for how you schedule members of the team going to see them if they're in a correctional environment, for example, after they've gone through a mental health evaluation, or timing it so that it's around the time they get visits from families, right? Thinking about how you help that person have these experiences and evaluations that are meant to help with the case, but that can be very triggering and distress inducing in the short term. And then thinking about structural factors and barriers when it comes to educational resources, occupational resources, right? What does the person need in terms of programming, how it needs to be changed, language, educational interventions, and understanding that if you are able to tie symptoms of avoidance or irritability or poor sleep, even if they don't meet full diagnostic criteria for PTSD, if you can tie those things to functional impairments, it's still a trauma. It's still a trauma and stress related disorder. It's still a part of the case, and it is still something that could be remedied through these psychosocial interventions. And so, with the consultation process, there's three big stages, right? And anybody who tells you they can give you a certain opinion before they've gone through the stages is somebody that you should be wary of. You also want to make sure that you're working with people who understand that it's important to make sure that you are clear on what a report would say if you were to have them write it before they start doing that. You don't want people spending hours on things that aren't actually helpful to your case. And so that first part, right, is information gathering. So that is you are engaging the expert, you're reviewing the records, you're interviewing the client and the collateral, you have the attorney meeting so that you're clarifying the question, and sometimes what I find is that that consultative process is not just around the interview with the client, but it's around thinking, rethinking, editing what that forensic question is. Not editing what the answer to the question is, but sometimes editing what question is asked so that you can have the most value in the consultation. Research, it can maybe background research or lit reviews that could be helpful, and then the review of relevant legal documents. So after you do all that, the expert is then able to share with the legal team or the person who has hired them. For us, client is you guys, not your client. And at that point, making it very clear what a report would or would not say, what the expert could or could not testify to. And that's also a really important time to share what you think the vulnerabilities are, right? So it's not just about the limitations of what you can testify to, but what you think could be potentially valid lines of attack from an opposing expert. And so the sharing of opinion page, the sharing of opinion stage is going to incorporate that as well. And that's a decision point for you as a legal team, right? About if you want a consultation product, such as a report or testimony, or maybe you just want them to help with rebuttal. So, there have been some cases where, you know, they contact me and my opinion is not favorable for the forensic question that they had for me, but maybe we still are engaged when it comes to how they cross-examine the opposing expert in the case that the opposing expert has overreached in terms of their opinion. So then, of course, that final consultation product is report, testimony, or just that consultation. So when we are going through this process, right, we have to think about things about the person's past, and we are doing it with the awareness that it's going to have a higher level of scrutiny than in our regular clinical practice. And when it comes to that forensic training, whether somebody's in a forensic psychology postdoc, if they're a postdoc, or a forensic psychology intern, if they're a psychiatrist, a fellowship, or they've done some sort of apprenticeship where they're working with other people, the key part of what you learn in that additional training is how this role is different, how you need to document differently, how you need to prepare to tell the story differently given this forensic mental health consultation role. So you have at the foundation of it, right, that someone has clinical acumen, interview and rapport building skills, ability to recognize diverse mental health determinants, and consultation and teaching skills. Because ultimately, especially if you end up in front of a judge or jury, but even in your interactions with the legal team, you want that consultant to be someone who can teach, who can take information that's technical and complicated and distill it and deliver it in a way that is accessible for people. And then that forensic overlay, right, is thinking about what this work is actually going to lead to and having the training to do that. So some differences in approach for treating versus expert clinicians. Your expert clinicians are probably should have a basic understanding of what is discoverable. They'll have more time for a deep dive related to your question, and they're going to have an awareness of the ultimate audience that is different. They're going to have clarity on the boundaries and limits of confidentiality in this setting and mindful of what cannot be unknown. So there are certain questions I know to ask the legal team about, is this fair game before I go in to see the person? Because if I'm on a stand, I can't unknow things that weren't favorable that, I didn't have to know if I didn't ask about it. A tip and something just to consider is that, especially in psychic injury cases, it's often helpful to have your mental health expert have a call or an interview with the treating provider rather than having that treating provider turn over their entire record if that's possible. Because that way you're not exposing the entire record. There could be things that are unrelated, but that are really sensitive information in that record. And 99 times out of 100, I can get what I need as the mental health expert evaluator by having a conversation with that provider rather than going through the entire record. And it's less hours that you end up getting billed for as well. Because we have the time and because of the adversarial nature, mental health experts are going to have a higher reliance on corroboration and taking the time to do that. And again, all this is going to be shaped by the forensic question. There could be things that are really important that a treating provider won't focus on as much because of that setting being different. And so your goal as a forensic mental health expert is that it's not too hot, it's not too cold, it's not too much, it's not too little. It's just right. It's just enough to answer that forensic question without unnecessary hours being billed and without, in psychic injury cases, unnecessary exposure to your client. There's also this understanding with the training that we receive that, every word counts and the need for precision and that there's a detail-oriented process. And so when you're thinking about working with people, understand the default in the field is not one of cultural or structural humility. And so particularly if you're working with someone from a marginalized population, them able to demonstrate some expertise in that is something that you want to look for because otherwise the picture painted of your client is going to be incomplete. Looking for if there's applicable clinical and treatment experience. So when it comes down to credibility, the ability to draw from my experience seeing kids, seeing families, knowing what people are dealing with, knowing what adults are dealing with, knowing how trauma shows up, how it ebbs, how it flows, is something that bolsters, the credentials and the stuff, from taking the test and reading the articles. Um, Also, if there are particular kinds of traumas, again, if these are marginalized populations that may have undercounted traumas, if they have scholarship, thought leadership, and things like that related to cultural and structural issues, that can also be helpful. And if they're able to really think about how they tailor their assessment, their formulation, and the evaluations the client and case needs. So, whether people meet diagnostic criteria or not, that's actually not difficult to do, right? It's just a matter of getting it and seeing if it matches up. The actual work, the part that's helpful, the part that puts it all together and that teases out how the trauma impacted the person's actions in a criminal case or how the trauma impacted the person's function in a civil case, that story is really in the formulation. It's really in somebody's ability to weave it all together in that psychiatric or that psychological formulation, not so much just whether they meet the diagnostic criteria or not. And so asking for things like de-identified sample reports is a good approach to see how they put it all together and if they put it all together in a way that felt accessible to you and that you thought could be useful for your particular case. And then thinking about structural and cultural humility, not only as it comes to the client, but court and other societal systems, right? So I've had cases where the presumption was because people didn't get care, they weren't sick. Well, in one case, it was a young man who lived in rural Georgia and had no car and had no insurance. So he had nowhere to get somewhere and no ability to pay for it if he did. And then, as I mentioned earlier, those sample reports that you're going to look for those elements in. And then, of course, child experience with those child clients. And for the sake of time, um, just talking about briefly some barriers to client disclosure. So if there's failure of recognition, opening the questions, there's guilt or shame, taking a non-judgmental stance, mistrust of authority systems, it takes time. It's just that rapport building of what is the symptoms, mental health support, and ways for them to deal with those symptoms if they arise, and then with repression or denial use of records. And with that, I'll pause and see if there's any questions. I know we're at time.
Thank you, Dr. Vinson. There were three questions that I put in the chat. I don't know if you saw them or you want me to read them off now.
I can pull them. Sorry, I couldn't see them with the
Nope, that's
screen.
okay.
I'm sorry. Um, how do you differentiate between trauma and general psychological distress? So when you're talking about trauma and stressor related disorders, there's something that happened at a particular point in time that you can kind of tie that distress to. So there are a lot of people who have mental health symptoms, anxiety symptoms, depression symptoms. They can't really tie it to something. When you're talking about a trauma and stressor related disorder, the differentiating factor is that there is some experience that you can pin it to. Now, often there are things that it can be connected to, but people haven't necessarily made that connection. But that's the difference in terms of how we think about it and how we diagnose it. Um, Common pitfalls attorneys make when trying to establish or dispute a psychic injury claim. I would say one of the biggest ones I see is clients coming into this process not understanding the degree of exposure that comes with being a plaintiff in these kinds of cases. That they really need to be prepared about the fact that someone's entire job is going to be to discredit what you're saying. And so even the evaluator who's hired by the attorney that you hired has to ask some really hard questions and has to ask about things that you may not see a connection to, and really helping them understand how that whole process works. The other thing that I'll say as a common pitfall is a hyper focus on PTSD and a hyper focus on therapy and medication. Because at the end of the day, medication is only a small part. Therapy is supposed to be a kind of environment where you can practice things you then go out and do in the real world. And so you want to think about things more broadly than that if you're trying to really get somebody back to their baseline. Do you recommend involving an expert early in the case in the strategy? And if so, what's the most effective way to integrate them in the case preparation? I think it can be, especially if you have, I've been on cases where there was a lot of resistance from the client or a lot of resistance to the family, um, or from the family, and it's hard to engage them. It's hard to get them to buy in. It's hard to get the client to listen to you. So sometimes acting in that consultative role, not even necessarily as a named expert, you've been able to think about strategies for how you counter that effectively. So yeah, it definitely can be. And I would just say you want someone who has enough cases under their belt to have a sense of how these things often play out, and someone who has clinical experience, relevant, timely clinical experience with the kind of demographic you're working with and with the forensic question or the trauma issue that's relevant.
Great. Thank you so much, Dr. Vinson. That was very insightful and informative. And thank you for your time, for being here. And if that's it, then we are done. The CLE code is 9481. And again, thank you so much, Dr. Vinson. I really appreciate it.
Thanks for having me.